I'm Miriam Rodrigues. I'm a genetic counsellor by training, but have been working in research for quite a while now. Let's say since 2011. And I'd like to give you some perspectives on clinical research using Pūnaha, the New Zealand Neurogenetic Registry and Biobank as an example. And I'm just going to zip through a few slides, and the really interesting bit of this presentation is actually coming from Denise Bentall, who will come up and speak shortly. Okay, so why patient registries? I think it is important to bear in mind that the purpose of the healthcare system is to deliver healthcare. It's actually not there to provide researchers with data. And I will really hope that this presentation and anyone who's setting up research that involves any kind of interaction with the healthcare system, in the same way that it's so important that we have people with lived experience included in our research teams, it's really important to have clinicians included in your research teams as well. And yes, it would be wonderful if we had SNOMED coding and all of this kind of thing. However, in the interim, a solution might be patient registries. So hopefully I'll convince you of that by the end of this talk. So we like to think that patient registries can address key challenges in rare disease research. As the numbers tell us, people with rare disorders aren't many, and it's natural that clinicians and researchers may not necessarily come across people with these conditions, and a registry makes it easy to find people with rare disorders. A registry can contain whatever it is you set it up to contain, but it could include things like patient-level data and genetic, the genetic variant that's responsible. It could be a longitudinal registry. It can be many things. So, talking about Pūnaha, the New Zealand Neurogenetic Registry and Biobank, we are set up as a research study. We've got HDEC approval. It's nationwide. However, we're housed in the neurology department at Auckland City Hospital. We went through quite a big process to work out where best to house the registry, and coincidentally Chris Higgins was involved in those discussions because years ago we used to work for the same organisation that was instrumental in setting up what has now become Pūnaha. And I remember, Chris, we went backwards and forwards just so many times on thinking, where would the registry best be? And I think the decision to place it within the healthcare system was one of the best decisions that we ever made, and that's because of the ease of access to clinical information. We are led by a neurologist, managed by a registry curator, that's me, and we have a governance structure that includes people with lived experience in both. We have a Māori consultation group and also an access committee that works with the biobanking side of things. So this looks awful. It's a real. It looks like knitting gone wrong. But this really is what a typical collaboration looks like, because these things don't always happen just in one particular way, and you have to be open to potential collaborations coming at you from all and sometimes quite surprising kind of directions. So this is an example of an academic collaboration where perhaps a student or a researcher comes to us and they don't necessarily know what we've got, and we don't know what they can do, and so we spend a lot of time talking about that and trying to figure it out, and then hopefully get an actual formed application that can go to our executive committee, and then we're able to provide the data that we've collected from the patients with the support of their researchers, from laboratories, and we're able to analyse and report that data back. Another example of clinical interacting with a pharmaceutical company around clinical trial recruitment. It's a similar, pile of knitting or whatever this mess might be, but there are some differences here, and a key one is that the registry is positioned really well to be able to invite people who are enrolled on the registry, to be able to invite them to consider the clinical trial. So something that we would never do is provide people's names and numbers and where they live and what they had for breakfast to a pharmaceutical company, but we will let people know about this opportunity that is there, give them as much information as they need to make the decision about whether or not they would come forward to participate. In our particular area, neurogenetic disease, there is not a long history of clinical trials, so people are not used to it, and they don't necessarily know what it means to be in a placebo-controlled trial. And it's another area of education and health literacy, and really supporting people to make the decision that is right for them. So we feel that Pūnaha EO, the New Zealand Neurogenetic Registry and Biobank, underpins really a lot, if not all, I'm not sure. I guess you don't know what you don't know. But I feel that we probably underpin most neurogenetic research in New Zealand. So the registry, where part of what we try and do is enable timely diagnosis, and we do have a Finding the Gene type study that we'll invite people into if the usual clinical methods of securing a diagnosis haven't worked. Then we know how important a diagnosis is. I was so pleased to see that it was one of the top things that came out of that survey was increased access to a timely diagnosis. So we do that. The registry on its own is not a prevalent study. It's opt-in, and so we don't pretend that everyone with a neurogenetic disorder is on the registry. But probably enough are that it means we are really useful when it comes to doing prevalence studies. And as anyone who's ever written an application knows, that top line is how many people in New Zealand have blah, 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 whatever it is. And so really the only way you can answer that properly is with a prevalence study. A registry doesn't answer that question, but a registry can help. Natural history studies, so we'll hear more from Denise about her experience with natural history studies. The registry is really useful to be able to recruit to natural history studies. Also other research studies, you might be characterising some particular aspect of a condition, and the registry is great to contribute to that. Clinical trials, like the example I just, or like that kind of template that I just showed you before. And then also what we're all aiming for is access to treatment. So we can do all of these things. We can do all the research in the world. And in the end of the day, we need Pharmac to fund the treatment. We need MedSafe to approve it, and we need Pharmac to fund it, and having good data that could be supplied by a registry is really useful in these situations.
Hi, I'm Denise Bentall, and thanks very much, Miriam, for your introduction and your work so far. I was diagnosed with myotonic dystrophy when we had 3 children under 5. I was flawed. I had no symptoms, but the disease is in my family. I was told I was mild to moderate and could expect symptoms by retirement. This seemed a long way off, knee deep as I was in preschoolers. Type 1 myotonic dystrophy, also known as DM1, is a rare, progressive, multisystemic neuromuscular disease. The severity of symptoms between individuals with DM1 varies dramatically, largely due to the number of trinucleotide repeats on the abnormal DMPK gene. The CTG repeats range from 50 to over 1,000. Babies born with congenital DM1 can be severely affected from birth. Mature adults with less repeats might have no symptoms at all and not know they have the disease. I have 278 repeats, so I'm one of the lucky ones. For a rare disease, it is relatively common, possibly up to 70,000 people in the United States alone, which is probably why multiple drug companies are interested in treating it. Initially, I wanted to find out more. Being a registered nurse and a midwife, I had access to the hospital library. There was nothing but bad news there. I learned I could look forward to cardiac arrhythmias, loss of muscle strength, diabetes, cataracts, cognitive decline, fatigue, muscle cramps, myotonia, swallowing and respiratory difficulties. As well, I gained the impression there was no point in even trying. There was no cure. Articles reported people with DM1 don't care when they get a positive diagnosis because they're generally apathetic. Well, that wasn't me. I also read that studies have shown there's no improvement in the condition of people with DM1 when they attend the gym. I liked that, as I hated the gym. Since there was no treatment, my husband Steve, over there, my best support person, and I decided to ignore it for as long as possible and focus on enjoying life while we could. For 25 years, we had lots of adventures together and with our 3 wonderful children. Everything from camping under the stars in the Australian outback to riding our motorbikes through Mongolia. We did all of the great walks and many of the great rides in New Zealand on a mission. The only impact the disease had on me in those years were bilateral cataracts, which were easily removed. Another thing I'm grateful for. Around 5 years ago, however, I noticed I was starting to have trouble walking upstairs and having issues with eating. Food would go round and round in my mouth. I didn't have the strength in my jaw to chew it. I would often spit it out. I started to cut food into tiny pieces, including between the tines of the forks. I never ate without a glass of water at hand in case food got stuck. Choking was a risk. My esophagus was determined aperistaltic by endoscopy. It was hard to have a conversation and eat at the same time. Eating out with friends was embarrassing as it took so long to finish my meal. I started exercising my jaw when the phone rang so I didn't sound drunk when I answered it at 10:30 in the morning. My speech was becoming slurred. People would find me hard to understand. I had been doing everything I could to maintain strength and fitness, even going to the gym, but I was losing ground. It felt often that I was inhabiting an 80-year-old body that just wanted to give up and sleep. So ignoring it clearly wasn't working anymore. And it was time to get proactive. I started a Iyengar yoga practice with my 84-year-old yoga teacher who's amazing, which has helped improve my posture and flexibility and my state of mind. In keeping with the times, I looked up Dr. Google. Where would we be without that? I expected to find depressing news, but much to my surprise, there are a whole host of wonderful people out there working hard for the benefit of people with DM1 and other rare disorders. I stumbled across the Myotonic Dystrophy Foundation in the United States online and registered for their online conference with some trepidation, expecting to be reminding of looming disability. Instead, for the first time, I felt hopeful. I attended their Meet the Drug Developer sessions, during which drug companies talked about magic little things called oligonucleotides, which no doubt lots of you are familiar with, that conjugate to Fabs, or antigen binding fragments, to enable delivery into the cell nucleus. Once there, these wonderful oligonucleotides break up the hairpin-like clumps of protein, in my case, that have been trapped in the nucleus, releasing them so they can get back to their usual happy protein jobs, helping to restore normal bodily function. That was a real wow moment, real hope, at last. I raced to find Steve to tell him to come and listen. Fortunately, people like Miriam Rodrigues and Richard Roxburgh hadn't been ignoring the rare disorders all this time, as many of you. The New Zealand Neurogenetic Registry run by Miriam was inspiring to read about. I joined that and heard about 2 opportunities. the observational end DM1 study, and a therapeutic drug trial. By my second end DM1 annual visit, it became apparent to the physio that my condition had deteriorated. I hadn't spotted it, but my hand opening time was now abnormal, indicating increased myotonia. While this was a shock, luckily it coincided with people in my age bracket being eligible for a clinical trial and while I was referred for screening. Steve and I then embarked on an emotional roller coaster, and it was an emotional roller coaster as we determined my eligibility. It involved 2 trips to Auckland from Hawke's Bay for a screening appointment with neurologist Richard Roxburgh and functional assessments with University of Auckland physiotherapist Sarah Mollett. Steve and I both found the neurology visit stressful. Richard had said study participant symptoms needed to be in the Goldilocks zone, not too bad, not too good, and my ankle dorsiflexion power appeared to be a bit too good. We both desperately wanted me to qualify for the drug trial as we had read the early phase 1 results on the drug companies' websites, which showed the medication was making a real difference. For example, 20% abnormal DMPK gene knockdown and 40% correction of missplicing of the proteins. All participants had increased muscle strength and decreased myotonia with minimal side effects. The drug appeared to be reversing the course of the disease. After an anxious week, we were overjoyed to find out I could participate in the 4-year trial. Real hope at last. The first 6 months were placebo-controlled, 25% chance of being on placebo, 75% chance of getting the real thing. Within a few months, I was noticing improvements. I ate a mussel without cutting it into tiny little pieces. I no longer needed a glass of water nearby when eating. I stopped worrying about choking. I could chat while eating again and finish my whole meal when out with friends. I stopped having to exercise my jaw before answering the phone. People who hadn't seen me for a few months said how well I looked. When I asked why they thought that, it was, don't know, you look better, your cheeks are filling out, you're walking more upright, or I don't know, you just look brighter. I feel like I have my 64-year-old body back again. It is wonderful. I have been on the trial for 9 months. I've had no side effects. I'm so grateful for the chance to get back to a normal life, and that in this trial I'm guaranteed the therapeutic drug for 3.25 more years. New Zealand is one of the few countries which has been able to offer this trial. Without the consistent behind-the-scenes work of people like Miriam and Richard, who never give up, New Zealand may not have been chosen. Richard and Miriam were instrumental in getting the equipment necessary to conduct the functional assessments required for both the NDM1 study and the clinical trial progress assessments. That's been photographed there above the bed. They deserve a medal. And thank you to University of Auckland's CAPEX funding for approving it. Once the drug trial starts, the scheduling support is fantastic. My flights get booked, Ubers paid for, accommodations provided if needed. The schedule is sent out months ahead so you can plan your life around the monthly or bi-monthly visits depending on the phase of the trial that you're in. Staff at New Zealand Clinical Research have been friendly, efficient, kind and professional. It has been a hugely positive experience. I'm so grateful for the opportunity to take part in this trial, which has improved my symptoms dramatically. I am also aware how lucky I am in that my background and circumstances have meant that I could get myself educated to make informed choices. I welcome the chance to help anyone with DM1 and other rare disorders to learn more about how to educate themselves about their condition and to find the opportunities available to them so they can benefit too. Thank you all for your ongoing work in this area, which makes a real difference in the lives of people with rare disorders. Because of you and this trial, my family and I can now enjoy more adventures and me being up to my knees in grandchildren.